Hello everyone, welcome to the sixth edition of Spotters and Boosters. This session is based on case-based study. The solutions to previous SDL file are given. You may please go through it and match with what you have gathered information from the text. Clinical case 1. Identify the nature of drug. An elderly patient, 65 years, was prescribed a blood pressure reducing drug for hypertension. This also reduced his pulse rate to 60 per minute. The prescribing doctor emphasized that the medicine should be taken regularly and should not be stopped abruptly, and the patient complied with the treatment. Of late, he has started feeling tired, fatigued, and has developed coldness of legs and feet. The sleep is also disturbed sometimes, but there was no dryness of mouth. The prescribing doctor gave vitamin, but his tiredness did not improve. Now the questions are, what could be the nature of the drug prescribed? Can patient develop symptoms be related to the medicine he took? Why should such drug not be stopped abruptly? Which other antihypertensives should not be stopped abruptly? And suggest changes in the treatment for this patient. Now the answer to question 1 is, the symptoms suggest use of a beta blocker, a non-selective beta blocker such as propranolol. It could be another one, but this is a prototype. A number of side effects which are noted by patient include mild sedation, sleep disturbance, peripheral vasospasm, fatigue, tiredness. All are observed in elderly when they are prescribed propranolol. Obviously, addition of vitamin will not improve his weakness. Question 3. Two antihypertensives which should never be stopped abruptly are beta blockers typified by propranolol and alpha-2 agonist typified by clonidine. Abrupt withdrawal of propranolol causes rebound hypertension, tachycardia, and may precipitate angina. This is because number of the beta receptors increase with continuous exposure to beta blockade, and abrupt withdrawal causes excessive stimulation of the number of unoccupied beta receptors by endogenous catecholamines. For clonidine, which is a centrally acting alpha-2 agonist, this drug decreases central sympathetic flow to reduce BP, and abrupt withdrawal will cause loss of this central inhibition. There is excessive catecholamine release from the presynaptic adrenergic neurons, resulting in excessive stimulation of alpha and beta receptors, causing hypertension, restlessness, tachycardia, vomiting, sweating, and restlessness. An additional mechanism is also there. It is said that there is a beta and alpha receptor supersensitivity. Question 5 was, if a beta blocker is needed, which one would you consider? I would consider a cardioselective beta blocker such as metoprolol, succinate, or atenolol. Alternately, the beta blocker group may not be re-prescribed, but a diuretic or ACE inhibitor should be preferred. Clinical case 2. A male 56 years of age attended urology OPD with complaints of difficulty in passing urine, poor stream, frequent urination, often disturbing his sleep. These symptoms developed gradually over past 6 months. Often he took drug for spasmodic pain abdomen, and he also noticed that his urinary has increased at that time. On examination, patient's build is normal, there is no anemia, there is no hypertension, and upon PR examination, Ella's prostate was found, and lab investigation showed no diabetes, normal lipid profile, and no elevation of the prostatic specific antigen. So carcinoma is almost ruled out. Sonography showed Ella's prostate with high volume of 43 ml, and middle lobe was protruding into the outflow tract, so that was causing symptoms. The urologist prescribed a medicine that contains two drugs to be taken once a day, preferably at night, and he also instructed to stop antispasmodic drugs. Now the pharmacology related questions are, Enumerate drugs indicated in this condition. Second, what could be the drugs used in fixed dose combination for this condition, and what is their pharmacologic basis of combining? Why did antispasmodic worsen his symptoms, and if he requires an antispasmodic for colicky pain or urinary frequency, which one would you prefer? Solution to case 3 is the benign prostate hypertrophy there, and it is producing obstructive and voiding symptoms. There are two groups of drugs. One is alpha-1 selective antagonist that relieve dynamic component of the prostatic hyperplasia, and the drugs include doxazosine, elfusosine, tamsulosin, and silodosin. Last two are highly selective and often used. And the second group is 5-alpha reductase inhibitors that reduce the fixed component, that is the size of the prostate, by reducing hyperplasia, and therefore they are also used. They are slow acting drugs. Now, a combination of A and B will produce improvement in dynamic obstructive symptoms, as well as the size of the prostate will reduce when given for a longer time. Tamsulosin silodosin is usually given with either dutasteride or finasteride as fixed dose combination. Pharmacology of these two drugs is depicted here. Finasteride and dutasteride are blocker of 5-reductase, therefore they reduce formation of dihydrotestosterone. Finasteride type 2 inhibitor in hair follicles and prostate, whereas type 1 and 2 both are inhibited by dutasteride. Dose-to-dose potency, dutasteride is approximately 10 times more potent, and half-life is very important, and that is, it is very long for dutasteride and it is 24 for finasteride. Comparing tamsulosin versus silodosin, alpha-1 selectivity is both there, but there is additional selectivity on alpha-1D with tamsulosin. The dose is 0.2 to 0.8 milligram, whereas doses of silodosin is 4 to 8 milligram. Here again, silodosin is somewhat less potent. Abnormal ejaculation has adverse effect occur with tamsulosin 18%, but retrograde ejaculation is reported in 22.8% cases. And the usual fixed dose combination is tamsulosin with dutasteride or finasteride or silodosin with dutasteride. These are the combinations which are commonly available at urologists. Answer 3 is the patient developed worsening of voiding symptoms because the antispasmodic he took had anticholinergic, antimuscarinic activity. So atropine-like activity will cause increase in urinary obstruction by contracting internal bladder sphincter and relaxing detrusor muscle. Answer 4. It's a norm to find out the underlying cause of pain abdomen before prescribing anticholinergics, and if there is a functional disturbance, then DROTA variant is a direct smooth muscle relaxants with phosphodiesterase 4 inhibiting activity, and it is not a cholinergic drug, so it can be prescribed. Dicyclomine is commonly used as a direct smooth muscle relaxant, but minimum anticholinergic activity on M1 and M4 is there, so it may also cause the urinary voiding symptoms in the elderly. So one may prefer DROTA variant to dicyclomine. If there are urinary symptoms requiring anticholinergic, then uroselective M3 antagonists are available: derifenazine, solifenazine, tolterodine, or fesoterodine. They should be used cautiously if there are irritative symptoms. Case 3 is a 13-year-old child who had severe vomiting and was taken to a medical practitioner who gave intravenous antiemetic drug for quick relief. About 2 hours later, patient developed facial spasm, inability to open jaw, abnormal eye movements, and tongue protruded out of the mouth. He was dull in consciousness, but pulse and blood pressure were maintained. The question is, what is the probable cause of the symptoms? Are these symptoms related to drug administration? Number one. Second, what could be the possible antiemetic drug that would have caused such reaction if possible? Question 3. What are various types of such acute abnormal movements the drugs may cause? And 4. The general practitioner had reassured the mother and gave another tablet to be taken 3 times a day. The child gradually improved. Solution 1. Acute drug-induced extrapyramidal reaction because there is a causal temporal relationship between antiemetic drug use and appearance of symptoms. Answer 2. There are two groups of drugs that can cause acute extrapyramidal reactions. One is phenothiazine antiemetics. Prochlorperazine is the most commonly used. Triflupromazine will also cause acute muscular dystonia and acute extrapyramidal abnormal movements, dyskinesias. The second one is prokinetic antiemetics. Metoclopramide, particularly in children when given IV, may cause dystonia and dyskinesia. So drug could be either metoclopramide or, but because blood pressure is maintained, so metoclopramide appears to be the plausible drug. Answer 3. Type of the extrapyramidal reactions caused by drugs. There are two categories: acute onset extrapyramidal reactions, acute dystonia and acute dyskinesia, we saw in this patient. And the B are subacute and chronic use can cause extrapyramidal reaction in the form of akathisia, drug-induced Parkinsonism, chronic tardive dyskinesia, and perioral tremor. In this setup, we have not included the neuroleptic malignant syndrome, which is characterized by different syndrome and set of many. Answer 4. What is the nature of drug given for the treatment of this condition? Now, centrally acting tertiary anticholinergics typical is benzhexol known as trihexyphenidyl, benztropine, bepridine, procyclidine or ferradine. Any of these drugs can be given to treat acute manifestations. Benzhexol is often given orally or parenterally. This boy received 2 mg tablet 3 times daily with a maximum dose 10 mg and he improved. Some antihistaminics with remarkable anticholinergic activity are also central acting, promethazine and diphenhydramine, Benadryl. Amantadine is an anticholinergic drug, has an anticholinergic activity, and mainly it is an anti-Parkinson's dose. But it is important to note that this, because of its anticholinergic activity, it is very useful in drug-induced Parkinson's syndrome, not in other reactions. So the lesson from this is that we should always avoid parenteral metoclopramide in case 4. A 48 years old alcoholic patient with a known history of joint pains presented with sudden onset of severe pain and swelling in the right big toe. He was febrile and was unable to sleep. Examination revealed a swollen joint. That skin was hot and movements were painful. Lab tests show leukocytosis with polymorphic neutrophilia. Uric acid levels were 9.4, normal should be less than 6 mg/cent, and ESR was also elevated. Synovial fluid examination was ordered and there were presence of monosodium urate crystals. So now, pharmacology related questions: how will you treat this patient? Acute condition, enumerate drugs that can be used for long-term management, and the third is acute, enumerate drugs that can precipitate. So in a patient with acute gouty arthritis, there is always usually mono or posi articular involvement as is in this case, and alcohol predisposes to acute attacks. The drugs which can be used in acute arthritis are NSAIDs, naproxen or indomethacin, and found to be very effective, providing quick relief. The specific drug for acute gout is colchicine with a loading dose of 1.2 mg followed by 0.6 mg hourly and later to a total dose of 1.8 mg per day. Colchicine provides very good relief but may cause diarrhea. It has to be noted. Colchicine 0.6 mg given twice daily also acts as a prophylactic drug if recurrent acute attacks are there. The third drug is glucocorticoids, oral prednisolone or intravenous methylprednisolone. Low doses, not high doses, but low doses would quickly resolve painful inflammations. Oral therapy with these drugs may be continued for 7 to most of the patient would require long-term management. So the answer 2 is use of xanthine oxidase inhibitors, febuxostat 40 mg. It is preferred over allopurinol because it is less likely to interact and dose adjustment is not required in renal impairment. Efficacy is comparable. Allopurinol is time-tested drug. Started low dose and maximum 300 mg per day can be given. Low dose is 100 mg. But it may cause adverse reactions, 2% hypersensitivity reactions and interactions, and those may be adjusted with renal disease. In addition, if other drugs are given such as 6-mercaptopurine, then there will be adverse drug interaction. The second group drug is uricosuric drugs typified by probenecid 500 mg per day orally, but it is contraindicated in renal impairment with creatinine clearance less than 50 ml per minute. Dotinuroid is a newer drug with uricosuric action and 1 to 4 mg per day is found to be effective. Another agent is the resburicase and pegloticase. Pegloticase is recommended for refractory cases. Case 4. Answer 3. There are few drugs that cause hyperuricemia: thiazides, loop diuretics, calcineurin inhibitors, cyclosporin, tacrolimus, pyrazinamide, ethambutol, niacin, low-dose aspirin, anti-cancer drugs, and cholesterol-lowering agent bempedoic acid diazoxide, which is used in acute hypertension. Three drugs are important, extremely commonly used: diuretics, pyrazinamide, ethambutol, and low-dose. Case 5. A 52 years old male presented with gradual onset of fluctuating muscle weakness and fatigue. He had double vision occasionally, difficulty in chewing, deglutition, and felt difficulty in keeping eyes open. Symptoms often worsened as the day passed and improved with rest. On examination, he had ptosis, weakness of eye closure. Skeletal muscle weakness was also noted. Reflexes and senses were normal. On examination, further examination, electrophysiology was done that demonstrated decremental muscle response to repeated 2 to 3 hours stimulation of the motor nerves. Sensory nerve conduction was normal. So, pharmacology related questions are: what is the suspected diagnosis and how can we confirm this diagnosis by a pharmacological test? Second is enumerate therapeutic groups in the drugs of groups which are used to improve muscle weakness. The third is describe pharmacological basis and adverse effects of cholinergic drugs which are effective in this disorder. And fourth is enumerate common drugs that may worsen muscle weakness in this. Answer 5 solution is the suspected diagnosis myasthenia gravis. It can be confirmed by hydrophonium test, which is used to diagnose and differentially diagnose cholinergic weakness from myasthenic weakness. Acetylcholine receptor antibody titer is also available and can be done by radioimmunoassay. Now, the drug groups useful in this disorder are reversible anticholinesterases, 1. Second, glucocorticoids. Third, immunosuppressives. Fourth, monoclonal antibodies, and others. Now, we will be describing some of them. Reversible cholinesterases are used to improve muscle weakness, although they are not curative. Neostigmine and pyridostigmine. Pyridostigmine is longer acting than neostigmine. These drugs combine covalently at the active site of the acetylcholinesterase enzyme. They carbamylated the enzyme, which is more stable. Therefore, there is no hydrolysis of endogenous acetylcholine that has a longer duration of action for about 3 to 4 hours, because carbamylated enzyme form is stable for this period. Now, since acetylcholine is available for action, there is improvement in the muscle power. Neostigmine 7.5 to 30 milligram taken orally 4 times daily. Sometimes atropine is read to antagonize its muscarinic action such as diarrhea, colic, urinary frequency. Pyridostigmine 30 to 180 milligram is given usually 3 to 4 times. Maybe a longer acting preparation may be given 2 times daily. Embinonium was used. Drugs that may precipitate myasthenia or may precipitate respiratory paralysis and muscle weakness are many. Quinolones, aminoglycosides, neuromuscular blockers, including dantrolene, chloroquine, and quinine. D-penicillamine long-term use may cause myasthenia-like syndrome, so it should be remembered that way. Erythromycin, other macrolides, and electrolyte disturbance always cause hypokalemia or hyponatremia, may aggravate. Now, homework for SDL6 is which neuromuscular relaxant causes malignant hyperthermia? 1. Second, which congenital myopathy malignant hyperthermia is likely to occur more? Third, mention a reversal agent used to terminate muscle relaxant activity of steroidal non-depolarizing drugs. 4. What are ADRs for alpha-1 antagonists? And 5. Any specific drug useful against chronic tardive dyskinesia. Sixth, enumerate 5 characteristics of edoponium hydrochloride. 7. How is atracurium inactivated? Which other drug undergoes spontaneous hydrolysis? 9. An anti-emetic drug that acts by inhibiting cholinesterase enzyme. And 10. In a patient who received succinylcholine for induction had prolonged paralysis about an hour, normally should have recovered in 10 minutes. So the likely cause of prolonged apnea is, you have to find out. Please find out the answers from the standard textbooks. All these textbooks describe what has been questioned in 10 questions here. Therefore, it is a platform for self-learning. Solutions to these 10 questions, you may visit the next video. Thank you very much.